Welcome to our video on cerebral venous thrombosis. Let's begin. For cerebral venous thrombosis, we'll discuss its definition, etiology, clinical presentation, diagnosis, and management. Cerebral venous thrombosis is an obstruction of cerebral veins or dural venous sinuses by thrombus. It can be classified based on anatomical location and etiology. Cerebral venous thrombosis can occur in any dural venous sinus. However, it is most common in the transverse and superior sagittal sinuses. Additionally, cerebral venous thrombosis can be classified as either septic or non-septic. It is 3 times more common in women than men. Here we have the non-septic causes of cerebral venous thrombosis. Any condition resulting in hypercoagulability can form a thrombus in the cerebral veins or dural sinuses. For example, malignancy can be the cause of this disease. Additionally, inherited thrombophilias such as factor V Leiden can cause hypercoagulability. Excessive estrogen in the setting of pregnancy or oral contraceptive pills increases the coagulation factor synthesis from the liver. Increased concentration of coagulation factors in turn can cause thrombosis. Polycythemia increases blood viscosity, slowing down the blood flow and predisposing to thrombosis. Nephrotic syndrome results in urinary loss of antithrombin 3 that normally inhibits activated forms of factors 2, 7, 9, 10, 11, and 12, which leads to hypercoagulability and potential for cerebral venous thrombosis. Neurologic procedures, such as lumbar puncture, can also precipitate cerebral venous thrombosis. High homocysteine levels can induce cerebral venous thrombosis because homocysteine alters the endothelial surface, resulting in excessive platelet aggregation. Thrombotic thrombocytopenic purpura causes platelet thrombi that occlude cerebral veins. Finally, sickle cell disease induces red blood cell sickling in low oxygen environments such as venous blood. Sickled red blood cells might occlude dural sinuses or cerebral veins. Let's move on to the septic causes of cerebral venous thrombosis. Any infection of the head and neck region can potentially cause cerebral venous thrombosis. Sinusitis can induce spread of infection from the paranasal sinuses to the dural venous sinuses. Infection can also spread to the cerebral veins and sinuses from the periorbital cellulitis, orbital cellulitis, and dental infections. Any infection in the mid-facial area is considered to be a risk factor for cerebral venous thrombosis because this area is partially drained by the dural venous sinuses. This is why the mid-facial area is sometimes referred to as danger triangle. Infection can spread to the dural sinuses from acute otitis media or meningitis as well. Here's the visual representation of the danger triangle. Infections in this area can spread to the dural venous sinuses and cause thrombosis. Let's talk about cavernous sinus thrombosis, a specific type of cerebral venous thrombosis. Cavernous sinus thrombosis, as the name implies, is thrombotic occlusion of cavernous sinuses, most commonly due to infections from the danger triangle. Specific findings of cavernous sinus thrombosis are explained by the nerves traversing the cavernous sinus. Involvement of cranial nerves 3, 4, and 6 can induce ophthalmoplegia because these nerves are responsible for eye movements. Damage to the sympathetic fibers immediately around the carotid artery can cause Horner syndrome with ptosis, meiosis, and anhidrosis. Finally, involvement of the first and second branches of cranial nerve 5 can lead to decreased corneal and maxillary sensation, respectively. This is the image showing cavernous sinus. You can appreciate the cranial nerves and the carotid artery going through the cavernous sinus. It is easy to see here how a thrombus in this small area could affect multiple nerves at one time. This is the patient with Horner syndrome. Please note ptosis and meiosis, characteristic of this condition. Remember that Horner syndrome can occur in patients with cavernous sinus thrombosis due to irritation of the sympathetic fibers around the carotid artery within the cavernous sinus. Cerebral venous thrombosis presents most commonly with a headache. Seizures are also possible in these patients. Since cerebral venous drainage is impaired, blood accumulation within the sinuses results in intracranial hypertension, presenting as papilledema, diplopia, nausea, and vomiting. Finally, cerebral venous thrombosis can also present with cranial neuropathies like tinnitus, facial palsy, or sensorineural hearing loss. Let's talk about the diagnosis of cerebral venous thrombosis. Magnetic resonance venography, MRV, is the test of choice due to its high sensitivity. CT venography can also be performed if magnetic resonance venography is contraindicated or unavailable. Findings in both studies include intraluminal venous thrombosis, absence of blood flow in the affected sinus, and the empty delta sign. empty delta sign represents a dural venous sinus with a hypodense center and hyperdense borders. This is an MR venography image showing the classic appearance of cerebral venous thrombosis. Take a close look at diminished blood flow in one of the dural venous sinuses. This is a CT scan of the head showing empty delta sign. The empty delta sign is a dural venous sinus with hypodense center and hyperdense borders. This is also indicative of a cerebral venous thrombosis. Let's pause the video and take a moment to consider this question. A 25-year-old woman comes to the physician due to diffuse headache and ringing in her ears for the last 2 days. She's also had nausea and vomiting. Her past medical history is significant for left maxillary periodontal abscess 1 week ago. She used to take oral contraceptive pills until 4 months ago, when she and her boyfriend decided to start a family. The physical exam reveals bilateral papilledema. Urine pregnancy test and serum beta-HCG are negative. Magnetic resonance venography reveals diminished blood flow in the superior sagittal sinus. What most likely predisposed this patient to her current condition? This patient presents with diffuse headache, ringing in her ears, nausea, and vomiting. The physical exam reveals bilateral papilledema, and magnetic resonance venography reveals diminished blood flow in the superior sagittal sinus. All these findings are consistent with cerebral venous thrombosis. She has 2 risk factors for cerebral venous thrombosis: dental infection and the oral contraceptive use. However, she stopped oral contraceptive pills 4 months ago, and she had the left maxillary periodontal abscess 1 week ago. Therefore, the most likely predisposing factor for this patient's cerebral venous thrombosis is her dental infection. Here are some other tests that we can perform in a patient with cerebral venous thrombosis. D-dimer can be performed, and it is usually elevated due to ongoing breakdown of the thrombus. However, low levels of D-dimer do not exclude cerebral venous thrombosis. A coagulation panel with PT/INR and PTT can be performed to check the patient's coagulation factor. A complete blood count can help us detect polycythemia, a potential cause of cerebral venous thrombosis. Erythrocyte sedimentation rate, ESR, and C-reactive protein, CRP, will indicate a possible inflammatory or infectious etiology of thrombosis. Blood culture can be performed to identify the causative agent in cases of sepsis. Finally, let's discuss the management of cerebral venous thrombosis. All patients with this condition require acute anticoagulation with low molecular weight heparin or unfractionated heparin. Low molecular weight heparin is the first-line treatment option. Unfractionated heparin can also be used. After initial stabilization and management of the patient, they should start chronic anticoagulation therapy with warfarin. Antibiotic therapy is only needed in septic cerebral venous thrombosis. An appropriate regimen includes vancomycin and ceftriaxone for staphylococcal coverage and metronidazole for anaerobic coverage. An 8-year-old boy is brought to the emergency department by his parents due to severe headache, vomiting, and ringing in the ears for the past day. 4 days ago, he finished antibiotic therapy for bacterial sinusitis. His vital signs include a temperature of 39 degrees Celsius, blood pressure of 100/80, heart rate of 92, and respiratory rate of 16. Physical exam reveals bilateral papilledema. Non-contrast head CT shows a hypodense mass with hyperdense borders and diminished blood flow in the inferior sagittal sinus. Which of the following is the best treatment option for this patient? A. Enoxaparin, vancomycin, and ceftriaxone. B. Enoxaparin and aztreonam. C. Unfractionated heparin. D. Warfarin. This young boy presents with severe headache, vomiting, and ringing in the ears for the past day. 4 days ago, he finished antibiotic therapy for bacterial sinusitis. His vital signs are remarkable for a fever of 39 degrees Celsius. The physical exam reveals bilateral papilledema, indicating increased intracranial pressure. Non-contrast head CT scan shows a hypodense mass with hyperdense borders and diminished blood flow in the inferior sagittal sinus. These are classic findings of cerebral venous thrombosis. This patient likely has a septic cerebral venous thrombosis due to contiguous spread of infection from the paranasal sinus. All patients with cerebral venous thrombosis should receive acute anticoagulation, preferably with low molecular weight heparin such as enoxaparin. Since this is a septic thrombosis, the patient should also receive the antibiotic coverage for staphylococcus and gram-negative bacteria. Vancomycin and ceftriaxone will be helpful in this case. Therefore, the patient should receive enoxaparin, vancomycin, and ceftriaxone. The correct answer is option A. Here's a slide reminding us of the management of cerebral venous thrombosis. Let's discuss why other options are incorrect. Option B is incorrect because aztreonam does not cover gram-positive bacteria. It only covers gram-negative bacteria. Option C is incorrect because low molecular weight heparin is preferred over unfractionated heparin for the initial management of cerebral venous thrombosis. Additionally, since this is the case of a septic cerebral venous thrombosis, the patient needs antibiotics. Finally, option D is incorrect because warfarin is used for chronic rather than acute anticoagulation in patients with cerebral venous thrombosis. And that concludes our lecture on cerebral venous thrombosis.